Hormone replacement therapy for perimenopause or menopause. Do you want to know everything about it so well that making a decision as to whether or not it's right for you becomes easy? Hi, I'm Dr. Patricia Mills, and welcome to the Wild Wisdom Show, where we're going to be talking about all about hormone replacement therapy, including best kinds, which ones you want to avoid, benefits and risks in perimenopause and menopause. And by the end of this, you should feel so comfortable about this area that when you encounter perimenopause or menopause, or if you're in menopause, no matter what age, no matter what decade of life you're in, you're going to know enough information to make a decision that you're comfortable with and that you're satisfied with. So let's dive right in today. So first of all, why would we consider hormone replacement therapy for perimenopause and menopause? And I've done a deeper dive in this in my previous episode in terms of hormonal changes and symptoms through the menopause transition, but let's review this briefly here today because it sets the context for why we're talking about certain kinds of hormone therapy, should it be something that you want to consider. So what happens during the menopause transition is that our ovaries start to run out of eggs. And as our ovary starts to run out of eggs, we start to produce changing amounts of estrogen. So over time, estrogen will go down so that when you're in menopause, about 4 to 5 years, after the menopause transition. So menopause by definition is 12 months without a period, right? Without menstruation. So about 4 to 5 years after that, you're going to be, you're probably going to be at your lowest point of estrogen in your body that you'll ever be in your life. So you'll kind of be at that lower level compared to the higher level that you are in when you're in your fertile years, knowing that that level in your fertile years is overall higher, but fluctuates month to month, right? As you go through your monthly cycle. And what happens is that as our ovaries start to lose egg quantity and it hits a certain threshold, because we're always losing egg quantity from the time we're born until menopause, we're losing those eggs over time as we ovulate. There's some damage that occurs with inflammation. And so you can actually lose eggs at a faster rate depending on your lifestyle. And again, I've talked about this before in a previous episode. And so, depending on your lifestyle, when you hit that tipping point where you have enough loss of eggs that your ovaries, which are the main producers of estrogen and progesterone in your fertile years, will start to make less of it. And the thing is, it's not like it gradually declines like a slow slope down. Estrogen actually will start to go up and down and can even sometimes be at higher levels than you were at in your reproductive years before you hit this tipping point with the number of eggs you have in your ovary. So what a lot of the symptoms that we have in our perimenopause and our menopause transition actually comes from the changes. So it's going from your normal levels of estrogen to low, and then very, very high to low again. So it's that shifting up and down. And you can think of it as more of a roller coaster of highs and lows of estrogen, overall trending downwards over the years. And that can happen over 4 to 8 years. But day to day, those levels will go up and down. And it's that big shifts of up and down that causes the symptoms. And because estrogen and progesterone also declines over time as we go through the menopause transition, testosterone does too, not to as great an extent as estrogen and progesterone, but it also declines. What happens is that the brain has receptors, which mean for estrogen and progesterone, which means that the brain senses and receives estrogen and progesterone, and hormones are signaling molecules. So estrogen and progesterone go to the brain and signal the brain to make the brain do things. So for example, it helps the brain regulate temperature. So when you go through menopause transition and your estrogen is starting to go up and down and all over the place, you might get hot flashes or night sweats. The progesterone helps with mood and with sleep. So you might start to run into issues with your mood, irritability, anxiousness, depression, and insomnia. And over time, the other thing that it could affect the estrogen progesterone would be the way your brain thinks. So your ability to remember things, your short-term memory, your ability to remember, to multitask, all of those what we call cognitive functions of the brain can also be affected during that transition period. And the brain, what's cool is the brain can adapt. So over time, the brain adapts to this changing levels, and especially when you're in that 4 years after menopause, now the brain has had like a pretty low level of estrogen and progesterone, and it's pretty steady. You're no longer having the highs and the lows. So you're going estrogen, progesterone at a certain level in fertility years. The estrogen starts going up and down and up and down, but overall trending downwards over time. Progesterone overall trending downwards over time, and that phase of adaptation, it can be a phase where we actually feel our symptoms the most. And then when we get into the menopause phase is when we're at a pretty steady state of low estrogen, low progesterone, lower testosterone, and then the brain can adapt. But the bones have receptors as well for estrogen, progesterone, and testosterone, mostly estrogen, progesterone. The vagina, right? The vaginal tissues, our joints, our tissues. So our whole body is affected by menopause, right? It's not just the hot flashes and the night sweats, our heart as well. So you can get racing heart or abnormal rhythms or what they call palpitations in the chest. So these things can show up. And for some people, it can be very problematic. Like it really disturbs your quality of life. It can disrupt your sleep. The mood can be so severe that you can't enjoy yourself. And over time, people can run into issues with really bad cognition if we are not supporting our brain health during this transition, to the point where you could get dementia and Alzheimer's in the future, and you could get osteoporosis, right? And so my approach is one to really support the foundational health using nutrition, lifestyle, and if necessary, sleep interventions and supplements if necessary, stress reduction. However, for some women, it's simply not enough. And then what can be a very helpful solution is hormone replacement therapy. However, what you need to understand is the right kind of hormone replacement therapy has been proven to improve night sweats and hot flashes and mood and sleep and libido, sexual desire, vaginal dryness, reduces the risk of urinary tract infections. It reduces the risk of osteoporosis. So the right kind of hormone replacement therapy does improve those outcomes. The wrong kind could give you an increased risk of breast cancer and clotting in the blood and increased risk of heart attacks and strokes. So I'm going to be diving deep into what kind of hormone replacement therapy you want to be looking into if this is something you choose, so you minimize the risks and maximize the benefits. Now, if you're watching me live, please feel free to put your comments in the chat so I can answer them for you. So now let's dive into types of hormone replacement therapy. And there's many different ways to talk about HRT. I'm going to say HRT sometimes. It's short for hormone replacement therapy. And so let's say we take all HRT that exists and we put them all in one big pot. One way we can categorize them is whether or not they're bioidentical versus non-bioidentical. So basically, for example, let's use estrogen. We have 3 different kinds of estrogen in our body. It's estradiol, which is our main estrogen, estriol, which is the main estrogen of pregnancy, and estrone, which becomes more dominant in menopause. And these 3 different kinds of estrogens, the hormone replacement therapy options, there are some that look exactly like our estrogen. So if it has estradiol, it looks exactly like our estradiol, or estriol, it looks exactly like our estriol. Those are the 3 main types that we have out there in terms of what's available in the prescription world. And some of them, actually, the estrogen therapies do not look like our estrogen. They don't look like our estradiol. They don't look like our estriol. They are similar, but they're not exactly the same. And what I have to say is that we have learned the hard way in the history of humankind that when we make a medication that looks similar but is slightly different, it can actually have major impacts on our body. And so what we have discovered is that in the case of estrogen and in the case of progesterone, and in particular progesterone, there's also bioidentical progesterone that you can get, and there's non-bioidentical progesterone, similar but not exactly the same. That can make the difference between whether or not you're going to increase your risk of breast cancer, So let's dive into, I'm going to dive into the details of this, but I want you to know that a lot of the research that was done that caused the concern of increased risk of breast cancer actually came from the use of non-bioidentical progesterone. All right. So already I want you to understand that there's these two big broad categories. Now, the other way to categorize the hormone replacement therapy is, again, if we put all of those back into the same pot, mix up the bioidentical and non-bioidentical together, and you separate them out again now with this classification, which is natural versus synthetic. Now, natural means that you were able to get it from nature. Synthetic means that someone took the building blocks and created it in the lab. And people sometimes make the mistake of thinking that bioidentical hormone replacement therapy, bioidentical hormones, is natural and non-bioidentical is synthetic. And that is not true. For example, you can have a bioidentical estrogen or progesterone that is synthetically made. So long as the manufacturer is really intentionally using those building blocks to make them look exactly like ours, they can be bioidentical. And there are natural options out there that are not bioidentical. So for example, estrogen, the most common used estrogen up until now, especially in oral contraceptive pill, birth control pills, has been estrogen from pregnant horses, pregnant mares' urine. So they take the urine from pregnant mares and they take the estrogen from that urine and they use that in the medication. Well, mares, horses, have 10 different kinds of estrogen. Their main estrogen is estrogen sulfate, which does not look like our estrogen. And the minimal amount of estradiol that they have is one of the least amount of hormones that these horses have. So they're natural, but they are not bioidentical. So this is a really important distinction. Natural estrogens and progesterones tend to come from plants, which is really cool. So, for example, progesterone, natural progesterone, that is also bioidentical, comes from wild yams. And you might think, well, why don't I just go out and eat a ton of wild yams? Well, you could do that. And you could there's wild yam creams and things like that. The difference there is that they go into the wild yam, they isolate that molecule, that bioidentical progesterone, and then they concentrate it. And they know the exact dose. And it's usually a higher dose than what you could get from nature. And you know the dosing, it's more consistent. So this is the difference between something like wild yam and a prescribed bioidentical progesterone that is of natural source that came from that wild yam. So you could see how you could have natural bioidentical, synthetic bioidentical, you could have natural non-bioidentical, and there are synthetic non-bioidentical. Some manufacturers are making synthetically creating hormones that aren't exactly like our hormones. I don't know why. I don't understand that process, but in fact, it was the most common progesterone that was used up until the time of the study that caused a concern with breast cancer was a non-bioidentical progesterone that was synthetic called medroxyprogesterone acetate, MPA. So it's been used, and that was one of the concerns that came out from what we're going to be talking about when we talk about risks. That synthetic non-bioidentical progesterone is what caused the potential increased risk in breast cancer in women. It wasn't the estrogen. The estrogen actually was slightly protective. It was the non-bioidentical progesterone. So we're going to be getting into these nuances. The other way that we can talk about HRT is whether it's compounded versus commercial. So at this point, you've talked to your prescriber, the person who's working with you on HRT. Let's say you've decided, or you're thinking about HRT, and you've decided, okay, well, I want bioidentical because it makes sense that it's exactly like the hormones in my body. So it's a predictable response. I know how it works in my body. Non-bioidentical, it seems like it has more risks associated with it, potentially increased risk of breast cancer if it's progesterone, right? So I just want to stick with the bioidentical just to be really on the safe side. And by the way, research that's coming up nowadays is really supporting this concept that bioidentical is better. And then you've said, okay, well, I don't really care if the bioidentical is natural or synthetic, as long as it's bioidentical. And that's where I'm at right now, personally. For me, it's okay if it's natural, it's okay if it's synthetic, so long as the molecule itself is bioidentical. And now they're going to say, well, do you want to have it compounded or commercial? They might give you an option or they might have a preference. And you to understand what the difference is. So commercial means that an industry like a big company, big pharma, has made this product and they make it in very large warehouses and they have a very standardized procedure. And because they are all centralized, they make it in the warehouses and they ship the products out to the pharmacies. Then the government can go in and inspect the warehouse or the warehouses, right? If they have more than one. And then with government inspection, now they can say it's FDA approved, right? It's Health Canada approved because it's been inspected. So the benefits of the commercial is that you are fairly certain that the quality, the procedure producing it is of sufficient quality that it's passed inspection. Now, some issues do arise even with medications that undergo this process, but the risk of that is minimized. The downsides with commercial is that they'll always make it the same way. So if there's a product in it that you develop an allergic reaction or sensitivity to, then you can't use that product. They also always set the dose. It's always going to be the specific dosing. And in order to get more or less, you might have to, for example, if it's a cream, you use a little bit more cream or a little bit less cream. Or if it's a tablet, could you cut it in half? Or if it's a patch, could you cut the patch in half? Like you're starting to have to problem solve. If, for example, the dose that they're giving you in estrogen, progesterone, or testosterone is too high for your needs, you don't have a lot of wiggle room with the commercial in terms of dosing. The other thing is that the commercial options are usually more expensive, but because they're FDA approved, they tend to be covered by insurance, whereas the compounded options are not. So what's compounded? Compounded means that the prescribing doctor makes a prescription, they give the exact dose that they want, and that dose can be less or more than the commercial, can be more tailored to your potential needs, right? Like where you're starting off, your history, your desires and that kind of thing in terms of what you want in terms of dosing. Then they can also decide, like, do I want this kind of cream or do I want this gel, right? They have a little bit more flexibility with how it's delivered and the ingredients in it. And then they send that prescription to the pharmacy. You take that prescription to the pharmacy. The pharmacist themselves, so long as it's a compounding pharmacy. So some pharmacies don't do compounding because literally it's like a chemistry lab where they have all the ingredients and they mix it together on the spot and produce that product for you, and then they hand it over. And that product could be it could be a cream, a gel, a vaginal suppository, right? It could be a capsule that you take by mouth. So they can mix and create these things. So the benefits of it is that you can get these changes in dosing. So you can discover, let's say you discover over time that your body's very sensitive to these hormones and you need minimal amounts. They can make a minimal amount. Also, the compounded options tend to have the options of having a bit of estradiol mixed with estriol. Estriol is a slightly less, well, it's actually quite a bit less strong than estradiol. It has about 1/4 to 1/7 of the effects. So for some people, they want to go that gentle route. And so compounded options have that, whereas commercial options do not. And you can start to mix and match. Like I want 80% estradiol, 20% estriol, 50% estradiol, 50% estriol, right? So that's the benefit of compounding pharmacies. Interestingly, they're not as expensive as commercial products. So if you're paying out of pocket, you don't have insurance, then for some people will actually choose to go with the compounded version. What's the biggest downside of compounded is that there's no on-site regulation. Unless the company has done the work of asking inspectors to come in and inspect and having like an inspection done, and they might pay for it to get it inspected and be certified in some way, but they're offering a product that's not FDA approved because it hasn't been made at these big warehouses. So the quality of the product will vary depending on the pharmacy. So, for example, the FDA has stated on their website that they've gone into some compounding pharmacies, not all of them, but some of them, and they've been appalled at the conditions, right? There's like a dog pet bed beside the, where they make it, and the sanitary conditions are not great, and so on and so forth. So one tip I have is that if you're going to go with a compounded pharmacy that isn't like made at a pharmacy that's very well known, very, has been inspected, as like a great reputation and so on, you're going with a local pharmacy that's compounding, you may want to book an appointment to speak to the pharmacist and maybe even the owner of the pharmacy, right? If they're different people, and ask for a tour and say, do you mind if I see how your compounding is done, just so I can get comfortable with that? Because I just, there's a lot of talk about commercial versus compounding, and I would like to support you in your local business. And I just want to feel really comfortable with your practices, right? That's an idea. Or asking them about their practices and so on. So there's just things that you can do to minimize the risks of going with a local compounding pharmacy. So again, the pros of compounding is the tailoring of the dose, tailoring of the ingredients. It's cheaper if you're paying out of pocket. The cons is that it's not necessarily there's no oversight in terms of inspections. So there may not have that degree of safety factor that you might get with the commercial product, which again is safety inspected, is FDA approved, tends to be covered by insurance, a little bit more expensive. But again, if your insurance is paying for it, you don't feel that extra cost. So those are the differences between compounded versus commercial. And you can get all of the bioidentical, non-bioidentical, all those things in compounded versus commercial. Compounded tends to be more bioidentical because prescribers that are using compounding pharmacies tend to be prescribing bioidentical because they're a bit more advanced in their understanding of bioidentical versus non-bioidentical hormone therapy. So that's just something that you tend to see in compounded versus commercial. But you can get synthetic bioidentical estrogen, and you can get synthetic bioidentical progesterone or natural options with with commercial as well. So both compounded and commercial will give you that variety. The other way to look at it in terms of a decision that you're going to be making with your prescriber is, am I going to do this? Am I going to take this medication by mouth or oral? Am I going to put this medication on my skin, or transdermal, it's called, through the dermis of the skin? And that can be, that could be a cream or a gel or a patch, sometimes an injection. Or am I going to take it vaginally? So a really local therapy, if what I'm trying to target is a really local issue, like dryness of the uterus, pain with intercourse, recurrent urinary tract infections. Let's say you want to prevent uterine prolapse, where the uterus caves down into the vagina because of the loss of elasticity of the tissue there from the loss of estrogen. Some women, it's so severe that they have to have a hysterectomy, like a surgical removal of the uterus. So using local vaginal therapies for those specific conditions and preventatively over time can be useful. The vaginal application will probably not give you enough relief from hot flashes and night sweats and more of the brain related symptoms, because what you put in the vagina might simply not reach the brain. It also probably won't give you the protection against the bone, the bone loss with osteoporosis. So it's a very local application. So that's one of the reasons some people would do a vaginal. Or let's say that you're doing something oral or transdermal with the estrogen. You might put a vaginal progesterone, because the risk of estrogen is one of the risks of estrogen is that if you use it without progesterone and you have a uterus, you could increase your risk of uterine cancer. And the progesterone, the bioidentical progesterone, protects you against that risk. So you could either take progesterone by mouth or by the vagina, like with a suppository or a cream or a gel, for example, to protect your uterus if you still have it. If you're on estrogen, putting progesterone on the skin is not strong enough to protect the uterus. So that's something that you talk about with your health prescriber. And so the decision between oral versus transdermal versus vaginal depends on, are you using the HRT for symptom management only? Like, I'm not feeling great right now and I want to use HRT while I'm not feeling great through my menopause transition, and over time I'm going to come off of it. Or are you using it for reducing your future risk of low estrogen and low progesterone related problems, like problems with brain health, like dementia and Alzheimer's? Are you trying to reduce your risk with bone fractures and osteoporosis? Are you trying to reduce your risk with uterine prolapse? So depending on what it is that you want, that will determine what you use. So for example, let's say that your issue is sleep. Well, it seems like oral progesterone is really, really helpful with sleep, but if you give it vaginally, it doesn't help with sleep at all. And progesterone seems to be really helpful for sleep, which is one of those things that it seems to be really, really powerful for. But let's say you're having issues with hot flashes or night sweats, and either progesterone or estrogen or a combination of both can be helpful. And then the thing about estrogen is that you should never take estrogen by mouth. Okay. So you shouldn't take progesterone on the skin if you're using estrogen, and you should not take estrogen by mouth ever. The reason being that estrogen, when it goes in through the mouth, it goes into the gut, it's absorbed into the blood, it goes to the liver. And when it's broken down in the liver, it causes an increased risk of clotting. It makes the blood thick so that it can clot, and that can clot in your legs, it can clot in your lungs, and it can cause issues with severe issues like really problems with your lungs and your legs. They're called deep vein thrombosis in the legs and pulmonary emboli in the lungs. So that is for sure an issue with non-bioidentical estrogen. It is probably an issue with bioidentical that seems to be a little bit less known, but estrogen is made by the ovaries, so your body isn't used to seeing estrogen by like coming in through the gut, right? It's usually made internally, and it seems like estrogen has a special quality where when it goes through the liver, through that route, through the gut, through the mouth, gut to the liver route, it can cause increased risk of clotting. So to be on the very safe side, stay away from oral estrogens and keep your estrogen either topically or vaginally. That's the best way to go. And then if you're adding on progesterone, you take it orally if you have problems with your sleep, right? And you can take it orally even if you don't, but it might make you too sleepy. So that's something to consider. Or take it vaginally, right? So you're either taking orally or vaginally if you're on topical or vaginal estrogen. All right. So the interesting thing too is that testosterone should also never be given orally because it does increase, it has a serious risk of increased risk of side effects. So testosterone is usually given topically or vaginally. And they haven't really made a testosterone that's specific for women in the commercial world. You'd have to use the one made for men and do like mini dosing of the testosterone. It's usually like a cream or a gel. Compounded, you can compound any dose, and you can also do it vaginally. So if the issue is with local vaginal dryness and pain with intercourse, and low libido, and you're talk to your therapist and your prescribing doctor, and you're thinking, oh, let's try some testosterone. Testosterone has been shown to be really helpful for low libido. Then you'd be playing around with these two different formulations to see what works best for you. All right. So, and then when it comes to preventing things like the issue with the bones and osteoporosis and the brain health, probably you would be looking at topical estrogen on the skin and not vaginal. Again, because when you put it on the skin, it's going to get to more of the body parts than if you just put a small amount vaginally. And same thing with progesterone. If you're looking for the brain benefits of progesterone, then you might be choosing to do oral over vaginal. But again, if you can't tolerate the oral because it makes you too sleepy, then you might go to the vaginal. And again, you might start with the commercial options if you're covered with insurance and you want to go low on your payments and not have to pay as much. But let's say that the standard dose of oral progesterone isn't really working for you, it's too much, it's too strong, you could compound to a lower dose. The other caveat for progesterone is that when you take it orally, you want it to be the oral micronized progesterone. What that means, micronized, means that the progesterone has been broken down into very, very small molecules that actually can be very well absorbed into the body. If it's not micronized, it's not very well absorbed. And you can get oral micronized progesterone through commercial or compounded. Again, the difference being with compounded, you can really play around with the dose, like as little as 50 milligrams of oral micronized progesterone. Whereas with the compounded, with the commercial, you're stuck at certain doses that you could try, but if it's too much, you could go lower if you need to with the more compounded options. So those are all the different options. The oral progesterone that was used that caused the increased risk of breast cancer was non-micronized, and it was non-bioidentical. And we don't even use that kind anymore, but we still have other non-bioidentical progesterones out there that are not micronized that people are using, that are being prescribed by doctors for things like fibroids, endometriosis, all the way through to perimenopause and menopause. So what you want to ask your doctor is this bioidentical and is this micronized, oral micronized progesterone? If the answer is no, ask them to switch the prescription to the, for example, commercial version, which currently right now is Provera as an example, or Prometria, those kinds of not, and I don't want to give names because, depending on when you watch this, it may be different options. So that's why you want to focus on the bioidentical micronized option, okay, when it comes to progesterone. And don't take any estrogen orally, right? It's either vaginal or topical. So you may need to rewatch this to really get those down, right? And make sure that you're really understanding these concepts, because I just downloaded a lot of information that I think is really important. I think the average woman should know this. It shouldn't just be in the wheelhouse of the prescribing doctor, so that when you go to speak to your prescribing doctor, you can have an educated conversation with them and help them decide what would be good for you in terms of trialing out, right? And I'm sure that most doctors would appreciate that, because they say, oh, I'm so happy to know that you want to try the commercial bioidentical option, right? And it's okay for you if it's natural and synthetic, so long as it's bioidentical. And it needs to be a micronized oral progesterone, no problem. I can prescribe that, right? So these are things that you can have conversations with, so that, because prescribers out there, they have a variety levels of experience. Some of them, Western medicine doctors, they have very minimal actual training. Most of their training is with the birth control options. So the IUD, which is a non-bioidentical progesterone IUD, the Mirena, or the oral contraceptive pill, which is the mare's urine, right? It's called Premarin, with another kind of progesterone in there, right? So usually non-bioidentical, by the way. So, you're going to get that level of training and expertise all the way through to someone like a doctor or a nurse practitioner or a naturopathic doctor, functional medicine doctor, who has done additional training and ideally is also certified by the Menopause Society, the North American Menopause Society, where they have a certification that you can take. And that's where you get that level of detail, right? And even beyond that, doing additional training in bioidentical hormone therapy and in compounding and those sorts of things. So you're really going to get a massive range. So just so you know, when you go to your gynecologist, they may actually have never received training in bioidentical hormone therapy, period. So don't be surprised if that happens. It just means you need to go to someone who has, so that they can offer you the full range of options and have a full-bodied conversation with you about this. And then the other flip side, so we've been talking about what is the right kind. I hope you feel comfortable by now. If not, please put in the comments, so I may answer your questions either live now, or if you're catching this on a replay, I can come back in and answer them for you. So now we're going to talk about the concerns with breast cancer, because this is often at times the number one block for women to use HRT for perimenopause and menopause. And I have to be honest, it was my number one block too. And now that I understand this study better, the research that caused this concern better, I'm actually not concerned about it at all. And I'm going to explain to you why. So the big study that caused a massive concern with breast cancer and HRT was called the Women's Health Initiative, which started in the late 1990s and then terminated after about 4 years in 2002, because they started to be concerned about this increased risk of breast cancer. And they had set a certain point of, they're like, if it goes beyond this risk, we're going to stop the study. Well, what happened was that they stopped the study. It became massive news. Everyone got scared and started, like, women who were on hormone replacement therapy and having massive success with it and experiencing tremendous benefits, which is why the study was done in the first place, because they're like, okay, it seems like women are really benefiting from this. Why don't we also see if it not only helps with hot flashes and night sweats and all these things, maybe it can also prevent heart attacks and strokes, which we have a higher risk of once we hit menopause, right? So they did this study, and they broadcast that they were concerned about breast cancer and shut it down. But when the researchers went back into the research and actually drilled down into the data, here's the finer details, okay? Problem number one with the results that make me, one of the reasons why I'm not worried about breast cancer is they were using the estrogen was the estrogen from mare's urine. So it was a natural non-bioidentical estrogen. And the progesterone was the synthetic non-bioidentical progesterone. So those are, and now we've discovered that over time, bioidentical progesterone is so much safer. It could actually protect against breast cancer. It has that potential. They're looking into that now. And again, the estrogen should be a bioidentical option, right? They gave the estrogen by mouth and the progesterone as well. So again, a second mistake that they didn't know at the time, right? Increased risk of clotting. So it gave estrogen by mouth. And then the actual data itself. So we're not even using those hormones anymore. The newer hormones and bioidentical options are so much safer. But let's say worst case scenario, you're using the worst kind of hormones for perimenopause and menopause, right? What they found was that they had it was a randomized controlled trial in the sense that they divided the women into groups, and they had one group that didn't have the hormones, one group that had their uterus, and so they were on estrogen and the non-bioidentical progesterone, and one group that didn't have their uterus, so they were only on the estrogen. What they found was for every 1,000 women who were not on any hormone replacement therapy, 4 of them got breast cancer. So there were women getting breast cancer even though they weren't on HRT, right? That makes sense. Unfortunately, that makes sense. When they looked at the group that had estrogen and progesterone, that risk went up to 5 in 1,000 women. So one more woman diagnosed with breast cancer. The group that had estrogen alone actually had less women had developing breast cancer, about 24% less, whereas the estrogen and progesterone group had 25% more. But isn't that a weird number? 25% more. It sounds like a huge jump, but it's only one woman per thousand. And the difference in that 25% versus 1 in 1,000 has to do with the use of statistics. So when you're saying the absolute risk, like the absolute number of women that got more breast cancer was 1 in 1,000. The relative risk, 5 relative to 4, is 25%. So they used the number 25%. It sounded astronomical. It scared the bejesus out of people. And then the cool thing actually is that research over time has shown that those women who did develop breast cancer, so if you took the 5 per 1,000 and the 4 per 1,000, right, on hormone therapy, not on hormone therapy, and they monitor over time, which they did, they monitored all these women over time. The woman who had been on hormone replacement therapy had a decreased risk of dying from the breast cancer. So it actually seemed protective against it being the kind of breast cancer that caused death, which is so interesting, right? So even the bad kind of hormone therapy that I personally would not use, myself, actually really didn't significantly increase the risk of breast cancer. It was very, very marginal from an absolute perspective, and actually decreased the risk of you dying from breast cancer. And the estrogen group only actually had a decreased risk of breast cancer by 1 in 1,000. So you see how it's very nuanced, right? The devil is in the details, so to speak. And now, fast forward, that was a massive study. Millions of dollars were put into it. It was prematurely stopped. So we don't actually know what would have happened if people had continued to be on it longer term. It was 4 years, right? And a bunch of recommendations came out of it that are actually not even really applicable anymore because we're not even using those therapies anymore. So now we have to use the smaller studies. And there was a KEEPS, KEEPS trial that did 4 years also using a smaller amount of the same kind of estrogen and a bioidentical progesterone, and they didn't see any increase in breast cancer, right? So you see the research is really shifting. Will we ever have a very, very large study like the Women's Health Initiative, again, using now non-oral estrogen and bioidentical progesterone? Probably not, because that was just so scary for funders and how much money was spent. So now we are relying on these smaller studies. And the other thing that these smaller studies are also showing is that the Women's Health Initiative did show an increased risk of clotting, those deep clots in the legs and in the lungs, as well as heart attack and stroke. And that now seems to be, when they're diving into that and trying to understand that, seems to be related to the oral estrogen, particularly the clotting. So when you take estrogen by skin or vaginally, it does not increase your risk of clotting. If you take it by mouth, it does. So again, that's why I went through the distinction of, asking if you're going to have estrogen, making sure it's not given orally. And if you're going to have progesterone, make sure it's bioidentical. Ideally, both are bioidentical. That's my preference as well. And if you're on estrogen, the progesterone should either be oral or vaginal, because that will protect you against uterine cancer. So now you're stacking the deck for you. You're making sure that all of these odds are for you. And it's really worth considering, because there's research coming out now that if you start estrogen and progesterone therapy within 10 years of your menopause, ideally within 5 years, 4 to 5 years. So again, menopause being when you're 12 months without your menstruation, that it does protect you from, we know for sure that it protects you from osteoporosis in the future and bone fractures that come along with it. We are seeing really good initial evidence that it could protect you against dementia and Alzheimer's. Okay. But that protection is when it started within that 5 to 10 year window, ideally 5 year window. When you started, if it's been more than 10 years after menopause, you may not get those benefits simply because the tissues have been so long without the estrogen and progesterone. It may be hard to reverse out of that, the loss, the changes as a result of the loss. However, when it comes to hot flashes and night sweats and vaginal health, urinary tract infections, vaginal dryness, sexual health, and those kind of more symptomatic things, insomnia, problems with your sleep, problems with your mood, if it's related to being in menopause, no matter what age you are, whether you're in your 60s or your 70s or your 80s, it doesn't matter. It can be helpful as treatment for your symptoms to feel better. So long as you are using the bioidentical options, right? And making sure you're not taking estrogen by mouth, et cetera, et cetera. So making sure you have those parameters in place will reduce your risk. And the thing is, there's no one study that is showing all of this in its entirety. I had to go through hundreds of studies, like hundreds of studies. I actually created the training program for the nurse practitioners working at Science and Humans, which is an online company that operates out of Canada. And you have online appointments with nurse practitioners, and they can prescribe you compounded versus commercial. They have the compounded done through a centralized pharmacy, and it gets shipped to your house if you want to, or you can get locally. I have no financial incentives for saying this to you. The reason I worked for them was because I moved to a small town, and I realized that when I go through menopause, I was not going to have any access to this kind of therapy locally because there's no doctor here doing this kind of medicine, right? So when they came to me, and with my functional medicine training, we do this training in hormone therapy and so on, they came to me. I dove even deeper into the research, particularly bioidentical, and it blew my mind. And it made me so comfortable with the concept of taking bioidentical hormone replacement therapy that now it's a no-brainer for me. When I go into menopause, I would start it for my future protection of, all the osteoporosis and brain health and that kind of thing. And then the question comes up, would you then stop it at a certain time? Well, again, it depends. If you're using it for symptom management and your symptoms improve after being on it for, like, let's say a year or 2 years, you come off of it and your symptoms are gone and you're feeling good, and you're not doing it for your future risk reduction of future health conditions like the osteoporosis and so on, then you don't need to go back on it, right? You used it for that period of time, that transition time, where the estrogen is going high and low and it's going crazy and all over the place and you're not feeling great, or that adaptation phase to low estrogen in the brain, right? So the hot flashes and night sweats, the brain adapting to the lowering of the estrogen. Most women do experience improvement in hot flashes as time goes on. Some women don't, as much as a third of women don't, in which case you could stay on that therapy for as long as you need to. It could be for life. Now, there's no studies specifically looking at this long-term use of bioidentical hormone therapy, but there are some large observational studies from places like France, like the European countries, where they've been using these therapies for a long time. And it seems like women, even in their 70s and beyond, are still gaining benefits symptomatically, how they feel from being on the therapy. Okay, so there's no study right now saying you have to stop after a certain period of time. So doctors who are saying you have to stop after 5 years, you have to stop after 10 years, that's based on the Women's Health Initiative, which we now know was faulty to a degree and actually not as worrisome as we thought originally. So the newer studies are looking like it's not an issue. And then if you're using it for the long-term preventative aspect, like you start it because you want to prevent bone loss, you want to prevent dementia and Alzheimer's, not that it prevents it, but it reduces the risk, right? There is, again, no study saying that you have to stop taking it. You could stay on that dose, right? And then you have to talk to your doctor in terms of how are you going to dose it, right? Are you going to do it every day of the month? Are you going to give breaks to your body, right? So that it's a bit intermittent. So you come off of it a little bit, back on it. Do you take it Monday to Friday and take Saturday and Sunday off? Do you take it 3 months of the month and 1 week off? Those are discussions you want to have with your healthcare provider. I personally think that the body should always have a mini break. So I like the Monday to Friday dosing idea. For now, that's where I'm sitting at. But just so you know, that like if anyone says you have to stop taking this after a certain amount of time, that is not true. There's no research supporting that in terms of the use of bioidentical hormone therapy. Okay, so I wanted that to be very, very clear. So let's go into how to decide if this HRT is for you or for not, right? So I have a few questions here. First is a comment. Hi, Chichum, thanks for joining us today. And she's saying there are so many non-hormonal, non-barrier options for contraceptives. That's right. Exactly. So I imagine a future where we're either going to have much better options for hormonal treatments for contraception, or women are okay, with using things like condom methods, which are 99% effective, as effective, if not more than the oral contraceptive when used properly, just like the oral contraceptive really when used properly. The other question that Cheecham has is that what is it in oral supplements that causes higher risks with estrogen? It's the fact that estrogen, when it's broken down by the liver, is broken down into what's called metabolites that increase risk of clotting. And estrogen that's made from the ovaries doesn't go through the liver in that way. So it doesn't have that same effect in terms of clotting. So it's not that there's something in the oral itself. It's the oral estrogen. It's estrogen taken orally. So when you take it by the skin or by the vagina, it doesn't have what's called the first pass effect through the liver, that very early entry point through the liver. Everything that you eat and goes through your gut has to go through the liver first before it goes into the rest of the body. And same with estrogen, same with medications. That's why medications can have a bit of a load on the liver. And so that is why. So I hope that answers your question. I know it's a little bit kind of hard topic to really understand it in its entirety, but I hope that's enough information for you to understand that concept. If not, put it in the comments and let me know. So how to decide if HRT is for you involves understanding what are the absolute contraindications, like you should not consider HRT in these circumstances, okay? So right now, the absolute, don't use HRT, right, if you have this condition, is if you have known, suspected, or previous history of a hormone-sensitive cancer, such as cancer of the breast, cancer of the ovaries, or cancer of the uterus, or endometrial cancer, okay? Now, for example, they say that if you've had endometrial cancer, uterine cancer, and it gets surgically removed and the uterus is gone and you're symptomatically having an issue with HRT, you may actually be a candidate because now there's not that concern with the cancer itself being activated by the hormones. So again, even though these are absolute, have a conversation with your doctor. Maybe you had a double mastectomy. Maybe you had, and then if you've had your ovaries removed as a result of ovarian cancer, same thing. You may be a candidate for HRT. And in fact, women who have had their ovaries removed, either preventatively because they have like the BRCA1 gene, BRCA2 gene, like high risk of cancer in the ovaries, they may actually be the ones who benefit the most from HRT, because when you surgically remove one or both ovaries, or when you surgically remove your uterus, your hormone levels will drop drastically and even lower than if you never had it removed. So in menopause, you will have lower hormones because the ovaries are still making a little bit of hormones. They are still contributing primarily the testosterone into the bloodstream. So you will get more severe changes and more severe menopausal symptoms if you have a hysterectomy, one ovary removed, or both. Okay. But if you have those ovaries or a uterus in place and it has cancer in it, same thing with the breasts, you do not want to take HRT unless you're really working with an excellent doctor who's using hormone therapy as a treatment, right? Like tamoxifen is a kind of hormone therapy that is used to treat breast cancer, right? It's different than our own estrogen, but in a way that's more selective. So that's where that therapy comes in. If you have active clotting in the blood, like a DVT or pulmonary embolus, or if you had previous issues with this, it's not for you. Now, the caveat being that was a concern with the oral estrogen. So something like a progesterone, topically or vaginally or orally, is still in the wheelhouse of something that you could potentially use. So again, talking with your doctor who really has been trained in this, for example, with the Menopause Society, right? If you've had a previous history of stroke or myocardial infarction, MI, that becomes a potential reason to not be on it. So again, talk to your doctor. If you have active liver disease, like it shows up in your blood work, for example, where your liver function is really failing you, you do not want to take estrogen or progesterone. You don't want to add to the burden of the body, of the liver. The liver may not be able to metabolize and break down these hormones, and you may run into toxic levels of them in your blood. So that's the main issue with liver disease. And if you're an active smoker, now some doctors will prescribe with smoking, but it's such an increased risk of clotting, even if it's not oral estrogen, that ideally you stop smoking before starting HRT if you really want to minimize your risks. Now, it's a myth that if you have a family history of cancer, breast cancer, for example, that you should not be on HRT. There is absolutely no evidence for this. So you do not need to, it is not a contraindication if you have a family history of cancer, a family history of heart attack, stroke, liver disease, etc. All of the contraindications have to do with your own history. Okay, so very, very important. And Trish, hi Trish, so lovely to see you here. She has a question. How does a family history of breast cancer affect individuals' risk for taking HRT? Just answered. Isn't that wonderful? It's like I'm reading your mind. So it doesn't affect the decision at all. You may not feel comfortable with that, right? But in terms of the prescribing doctor, they can prescribe it for you with no concerns. And there's no evidence that it'll increase your risk of breast cancer. Again, especially if you're using the bioidentical options, right? Staying away from that synthetic, from that non-bioidentical progesterone. Another question that Trish has is, does a history of migraine impact individual risk with HRT? So it depends. That's a great question, actually. So if you have non-aura migraines, then it doesn't. But if you have migraines with aura, which are the kinds where the brain is affected, and so you start to see things like with your migraine coming on, then you could be at slightly increased risk. And so you do want to talk to your provider because you want to understand, like, what are your other risk factors? Like, do you have any problems with high cholesterol and, metabolic issues? Are you at increased risk for heart attacks and strokes, plus your aura? And then also when you're using HRT, sometimes it can make migraines worse, and sometimes it can make it better, right? So typically migraines get better in menopause. However, not for everybody. And it seems like the migraine with aura may put you at increased risk with HRT. It's not an absolute contraindication, okay? It's not a hard no, but it's a conversation with your prescriber. Cheecham is asking if I have a printed list of these contraindications. What I recommend is that you go to the Menopause Society, the North American Menopause Society, and they have this information on their website. They have the contraindications as well, and you can also search their toolbar. The types of bioidentical options I mentioned, I don't have a list. They're changing all the time, right? There's so many options on the market, it would quickly become outdated. So you have to talk to your prescriber and just be like, I really want what you're prescribing me to be bioidentical. And then the prescriber would have a list of what they work with, what they're comfortable prescribing. So again, every prescriber, for example, some prescribers are very comfortable with Biest or BS, depending on how you pronounce it, BIEST, which is a compounded thing, but some are not, right? Some will prescribe commercial and some will not. So the general concept of it being bioidentical is what you want to stick with versus me listing off a number of different products that could change in the blink of an eye. So I hope that helps. The reasons, again, so then again, reflecting, what am I using this for? Am I using this for symptom management versus risk prevention? And remember, it can show up in so many different ways. You can have issues with your heart and you go to a cardiologist and the cardiologist checks you out, does EKG, all this stuff, and is like, your heart is fine. And you're there, you're like, I'm not crazy. My heart is not feeling well. I'm having fluttering and all these things, whatever. It could actually be menopause, and the treatment is actually HRT. And you would actually have to be seeing a hormone prescribing therapist, not a cardiologist. So just remember, when you're going through the menopause transition, what you're experiencing is real. You're not crazy, and you do not have to suffer through it, right? There are options available to you. There are also some non-hormonal options for those of you who have absolute contraindications to HRT. And again, you want to talk to your prescribing doctor because what they're comfortable with, depends on the doctor. But for example, low dose antidepressants can sometimes be used because, again, a lot of the symptoms come from the brain and the antidepressants affect the brain. So there are some options with that. But if you don't have a contraindication to HRT, if I were to choose between HRT and low dose antidepressants, I would personally choose the HRT because it's actually more of a root cause solution. It's helping you supplement the deficiency, right? So, whereas the antidepressant does not, right? So what I talked about age to start and for how long right now with the bioidentical options, so long as you're respecting those rules of thumb of non-oral estrogen, making sure it's bioidentical progesterone, for example, you can start at any age in terms of, perimenopause to menopause, having symptoms. And again, there is no research saying that we have to stop at a certain time. And in fact, there's some long-term studies done on cohorts where women in their 70s are using it and they're experiencing better outcomes than the women who are compared to them in that same cohort who are not. So there is really no age to end as of right now, but always staying tuned to the issue, to like the research. The other question that some people have is like, do I need to test my estrogen and progesterone and testosterone levels before I start? The funny answer to that is actually no. So if you're in perimenopause, um, your estrogen levels could actually come back really high as you're having these menopausal symptoms, right? Perimenopausal transition symptoms, because remember, estrogen can go high and it can go low during those initial few years, the early and late phases of perimenopause. As you get into menopause, like the 4 to 5 years after menopause, then it's more steady. Then having low estrogen, on your blood work, you'd be like, yeah, it's low, right? Like you test it, it's low. But it's not like if you're experiencing hot flushes and night sweats and your estrogen comes back normal, does not mean that you shouldn't be benefiting from HRT. With HRT for perimenopausal symptoms, you treat the symptoms, not the blood work. Then you do blood work over time, but you do a baseline blood work just to have a future comparison out of curiosity, really, but not because of a treatment decision point. Then over time, you might repeat the blood work every 3 months to 6 months while you're adjusting the dosage just to make sure you don't get toxic, like really too high in your dosing, right? Based on the blood work. You can usually tell in the body when that happens. So if you start to get too much breast tenderness or weight gain or irritability, right? Like changes in that way. With testosterone, you might get some increased hair growth, a deepening of the voice, enlarging of the clitoris. Those are more indicative of whether or not your dose is too high. You do the blood work just to be safe and check, but the one blood work you should actually get done before you start HRT is actually testing for thyroid health. Why? Because hypo or hypothyroidism is very common in women transitioning through their menopause, and it can show up as menopausal symptoms. So it can seem like it's menopausal symptoms, but it's actually related to your thyroid. So for example, thyroid can cause weight gain. It can cause problems with sleep. It can cause problems with mood, with skin, with hair, right? So you want to make sure you're not missing a thyroid issue, because in that case, you would, for symptom management, you would look at the thyroid and you would support the thyroid again with foundational approaches, maybe some thyroid medication if you need it, right? If it's hypo and all those sorts of things. And then you would decide, if your symptoms are better, you would decide, do I still want the HRT for as a top up, or do I want it as a future risk reduction? But again, you want to make sure you screen for thyroid related conditions, and your prescriber should know how to do that, right? Testing for hypo or hyperthyroidism and those sorts of things. For monitoring and side effects management, at first, the first prescription is the doctors or nurse practitioners or whoever's prescribing for you. It's their best guess as to what you need. It is not necessarily going to be the final prescription. It's a starting point. And then you discover over time, do I need a higher dose? Do I need a lower dose? Do I need to switch from oral progesterone to vaginal because it makes me too tired? Or actually, insomnia is really a big issue for me and the vaginal didn't help enough. Can we switch to oral? Do I want to have a slightly less estrogenic effect because I'm noticing I'm getting a bit of breast, tenderness or whatever? Can I lower the dose or go to a estradiol estriol formulation like Biest, right? So these are conversations that you need to keep having with your doctor. By the way, one of the most common side effects is to get your period coming back again. right? Especially when you're in menopause. And for a lot of women, some women don't mind. It's a reawakening of the tissues, right? It's kind of like you're getting back into that rejuvenated state, but some women really don't like that. And so then you might switch to going from intermittent to continuous dosing through the month with no breaks. It can take 2 years for that side effect to go away. Some women never have it, but it's a common enough side effect that you should just be aware that it can happen. Don't freak out about it, but always, always make sure to maintain an open communication with your prescriber. So at first, you may be going to see them every 3 months, maybe even a phone call 6 weeks after the first prescription, just to see how it's going, making sure everything's tolerable, right? Then 3 months, again, touching base. And so at first, it may be every 3 to 6 months that you're seeing them. Once you have a prescription that's working for you in that moment, then you can go down to seeing them every 6 months to a year, but making sure you're always touching base with your prescriber, because sometimes the research is updated. There's some optimizations to the therapy that you can do. Your needs change over time. So you don't want to just, get the prescription and then buzz off. You want to make sure that you're having that, those touch points with them to make sure that you're not missing out on it. Here's some questions here. Chicham is saying, have I already discussed wild yam? Yes, I have. So you'll definitely want to watch the recording for that. And we have another person here joining me saying that I've seen some research mentioning that HRT could encourage regrowth of endometriosis after excision surgery. I'd appreciate your thoughts. Thanks so much for this conversation. Yeah, so it is possible. I haven't seen that specific research myself. Just thinking about it, if your endometriosis is caused by an over-excess production of estrogen in the tissue itself, which usually comes from inflammation in the body. So if all you've done with your endometriosis is the surgery and you haven't addressed the root causes of your endometriosis, then adding HRT to the mix could make it regrow. So if you're watching or listening to this, I highly recommend going to my endometriosis playlist on YouTube, and I go through all of the root causes, and it's nutritional and all these things, toxins, with strategies to address them. Plus, I have a video on supplements to support the reduction in inflammation and all those sorts of things that have been evidence-based and proven in research. So if you have anything like fibroids or endometriosis, you really want to make sure that you've got your foundational health really, really nailed down, which I will address. And then here's another great question as well. My functional health practitioner recommended a blood test as well as the Dutch test. Are tests of saliva and urine, such as the Dutch test, useful? All right, so this is a super controversial topic. The Dutch test is the comprehensive dried urine test, okay? And it tests estrogen and progesterone and cortisol and DHEA, and you can do urine, you can do saliva testing. What the government covers, for example, in Canada and in most countries, is blood tests. Blood tests have been the most studied. In research, they have been the most used, and they have been validated for absolute, like knowing how much estrogen you have and know how much progesterone you have and how much testosterone you have and how much free testosterone you have. So the testosterone that's not bound up, the testosterone that's available to you. What the Dutch test adds, like it's an additional benefit, is that it measures how much breakdown products of estrogen you're peeing out, and are they the kind that tend to cause cancer more than the kind that doesn't. So when you break down estrogen and you pee, and your body like has broken it down in the liver, and then the liver dumps it out either into the bloodstream, so you pee it out, or into the bile, so you poop it out. Depending on your genetics and where you're at with your foundational health, right? Your levels of inflammation, your levels of liver health, and that kind of stuff, you might be making more toxic estrogen. So if you're taking hormone replacement therapy, you definitely want to make sure that your liver health and your gut health is really good, because you want to be eliminating the estrogen that's being added in, and you don't want to be reabsorbing it. So how to detoxify estrogen from the body is another video that I made that you may want to look into, okay? Especially if you're taking HRT. Is it necessary to do the Dutch test in addition to the blood test? No, it's not necessary. It is optional. It is interesting. If you have a very high history of breast cancer in the family, you may want to do it. because it'll give you a bit more of an indication if you're trending in that direction or not, of making more of the toxic estrogen than the not toxic estrogen. But it is not necessary to do. And the reason I say that is because it can cost $300 to $600. And for some women, it's prohibitive. Like they wouldn't be able to afford that. So it is not necessary to do it. Is it helpful? Sure. But is it necessary? No. The blood test is sufficient. And again, remember, you do not even need to do the blood test to start the therapy if you're symptomatic and you're going through menopause. It's great for monitoring over time. And the blood work is more than enough for that. So optional Dutch test. Cheecham is asking, when referring to the prescriber, do you mean the nurse practitioners I mentioned? I'd feel like bringing this information to my family practitioner wouldn't do the potential benefit justice. No disrespect intended. Absolutely, Cheecham. I agree with you 100%. Let's be very respectful of doctors and understand that not every doctor is trained in everything. Family doctors are not trained in hormone replacement therapy. They are not trained in menopause, perimenopause hormone replacement therapy. They are only given the toolbox of the contraceptive options, and that's pretty much the limitation in most of their toolboxes, with some exceptions. And that doesn't make them bad people at all. It's simply a reflection of how they're trained. So, for example, physiotherapists, right? Some physiotherapists undergo general physiotherapy training, and some physiotherapists do additional training in pelvic floor physio, some in knee. They become really good at the knee. Some become really experts at the shoulder. So why would you go to a pelvic floor physiotherapist if you have a problem with your shoulder, right? So don't go to your family doctor unless they've done additional training like the Menopause Society certification. If you're having a question about hormone replacement therapy in menopause or perimenopause, it's almost unkind to have that conversation with them because they're not prepared to. They're not equipped to. Some doctors will be very honest and say, "I honestly don't know. I'll see if I can connect you to a gynecologist, but I actually don't even know if the gynecologist will be able to have this conversation with you, right? Because not every gynecologist has this additional training either." So then it becomes up to you. So you may want to contact the Menopause Society and see who's been certified. That's one way to do it. Science in Humans, again, in Canada, it's an online company that has nurse practitioners trained. What's nice about that is that sometimes when you see a naturopathic doctor, a functional medicine doctor, you're paying $300, $400, $500 a visit. These nurse practitioners, it's much more affordable. Would it be amazing to have a family doctor or gynecologist that's covered through public health insurance that understands this conversation? Absolutely, it would be amazing. If you find that person, let me know. It's very, very hard to find, right? So that is why. But it leads to that question about what is absolutely necessary if you're going to start HRT, and even if you're not, is your foundational health. Because if you have problems with inflammation in the body, because menopausal symptoms are worse with inflammation. So your hot flashes and your night sweats, your osteoporosis, your dementia, and your Alzheimer's, all of those things that become increased risk in menopause, it's like turning up the dial, turning up the volume. The risk of that becomes even more, and the symptoms become more severe if you have inflammation in the body from a lifestyle that you've been getting away with up until now, but when you transition into menopause, you don't have the resilience for it anymore, right? It's like that elixir of youth has run out. Maybe your sleep, you haven't been prioritizing sleep enough. Your stress reduction is not a priority in your life. You're not exercising. If you're not strength training, doesn't matter how much HRT you take, you're still probably going to get osteoporosis. Doesn't matter how many calcium supplements you take, you're still probably going to get osteoporosis. You need to strength train. So again, foundational health is key. And you may want to go back to some of my previous videos and look at how to optimize sleep for hormone health, how to eat for hormone health, how to exercise for hormone health, how to detoxify your estrogen for hormone health. Because even if you're not using HRT, but particularly if you are, you want to make sure that your body's ready to receive it so that you do additionally minimize all of those potential risks, such as the breast cancer and the clotting and the strokes and the heart attacks, which with a lifestyle that doesn't suit you, the risk of that happens regardless of menopause, right? So this is where I just want to make sure that we end the conversation of HRT with that understanding that your whole body health needs to be supported through your lifestyle and through your daily habits. And from that place, using the tips and strategies that I've shared with you in this video, From there, you can make a decision and feel very comfortable that you're really minimizing all of your risks for these future occurrences and maximizing all the benefits, because you may need less prescription therapy, or no prescription therapy if you're doing all the things to support your body health. So that's a really great thing about foundational health. So I want to thank everybody who joined me today live. Thank you for your attention. Thank you for your time. If you enjoyed this, please subscribe, save, and share. Share it. You never know when someone that you love might benefit tremendously from this information. And again, if any questions come up after the fact, pop them into the comments on YouTube. That's where I go and I check my comments and I make sure I answer them. If I can answer them for you, I will. And I'll do my best to stay on top of the research so that that information stays current. So I hope you have a really, really wonderful rest of your day, evening, or night, depending on when you catch this. And I will see you next time. Bye. Bye, everybody who joined. It was a pleasure interacting with you today. Bye.